Did you know that every 65 seconds, someone in America develops dementia? That's nearly 1,000 new cases every day. But here's what might surprise you. Some cases may be linked to medications sitting in your medicine cabinet right now. You've been told these pills are safe, routine, even essential, but emerging research suggests we need to be more careful. Many seniors are unaware that certain medications they're taking could potentially affect their cognitive function over time. While no medication directly causes dementia, research shows that some drugs may increase risk factors or accelerate cognitive decline in vulnerable individuals. A growing body of evidence suggests that one class of drugs may increase dementia risk in some seniors who use them long-term. This article examines 9 medications that research has linked to potential cognitive concerns, ranked from commonly overlooked to most concerning when used inappropriately. Medication number 9, diphenhydramine, Benadryl. Diphenhydramine is that familiar pink pill millions trust to help them sleep, soothe allergies, or ease cold symptoms. It's inexpensive, over-the-counter, and probably sitting in your medicine cabinet right now. But what many don't realize is how it works in your brain. Benadryl belongs to a group called anticholinergic medications, which block a neurotransmitter called acetylcholine. This chemical helps your brain form new memories and maintain alertness. As we age, our brains produce less acetylcholine naturally, making us more sensitive to drugs that block it further. Multiple studies have found associations between regular anticholinergic use and increased dementia risk. A notable study in JAMA Internal Medicine followed over 3,400 adults aged 65 plus for a decade and found those with the highest cumulative anticholinergic exposure had a 54% increased risk of developing dementia. Important note, this doesn't mean Benadryl causes dementia, but rather suggests a potential association that researchers are still studying. Smarter choices. For occasional use, Benadryl remains relatively safe for most people. For allergies, consider newer non-sedative options like loratadine, Claritin that don't cross the blood-brain barrier. Avoid PM formulations that rely on diphenhydramine for sleep. Always consult your doctor before stopping any medication. Medication number 8, proton pump inhibitors, PPIs. Omeprazole, Prilosec, and esomeprazole belong to the proton pump inhibitor family. These powerful acid reducers are often prescribed for heartburn, GERD, and ulcers. They're incredibly effective at what they do, sometimes too effective. The concern isn't the medication itself, but how it might affect nutrient absorption over time. PPIs can interfere with vitamin B12 absorption, and B12 deficiency can mimic dementia symptoms. Some studies have found associations between long-term PPI use and increased dementia risk, though the relationship isn't fully understood. A 2016 study in JAMA Neurology examining over 73,000 German adults found that regular PPI users had a modestly increased risk of dementia. However, it's unclear whether this was due to the medication, underlying health conditions, or other factors. The nuance: PPIs are often medically necessary and highly effective. The key is using them appropriately, at the right dose, for the right duration, under medical supervision. Balanced approach. Work with your doctor to find the lowest effective dose. Consider periodic drug holidays if medically appropriate. Ensure adequate B12 intake through diet or supplements. For mild symptoms, H2 blockers like famotidine may be sufficient. Medication number 7, bladder control medications. Oxybutynin, ditropon, is commonly prescribed for overactive bladder, a condition that significantly impacts quality of life. Like Benadryl, it works by blocking acetylcholine, but it more readily crosses into the brain. Research has consistently shown that strong anticholinergic medications like oxybutynin are associated with cognitive concerns in older adults. A 2019 BMJ study found that people over 65 using strong anticholinergics for extended periods had increased dementia risk. The challenge is that bladder control issues are real and distressing. The goal isn't to avoid treatment, but to find the best treatment for each individual. Modern solutions. Newer medications like maribegron or Mybertriq work differently and don't block acetylcholine. Behavioral therapies and pelvic floor exercises can be highly effective. If anticholinergics are needed, use the lowest effective dose. Regular medication reviews can help optimize treatment. Medication number 5, statins. Statins like atorvastatin and simvastatin are among the most studied medications in history. They've prevented countless heart attacks and strokes, yet some people report memory concerns when taking them. The research on statins and cognition is mixed. Some studies suggest potential cognitive effects, while others find no impact or even protective effects. The FDA requires statin labels to mention potential memory issues, but emphasizes these are typically reversible. Recent large-scale studies, including a 2021 analysis in JACC, found no consistent link between statin use and dementia in older adults. However, individual responses can vary. The reality: for most people, the cardiovascular benefits of statins far outweigh potential cognitive risks, especially given that heart disease and stroke are major dementia risk factors themselves. Personalized approach. If you experience memory changes on statins, discuss with your doctor. Some statins, like pravastatin, may have fewer cognitive effects. Don't stop statins abruptly, work with your healthcare provider. Focus on overall cardiovascular health, which protects the brain. Medication number 5, benzodiazepines. Benzodiazepines like lorazepam, diazepam, and alprazolam and Xanax are powerful medications for anxiety and sleep disorders. They work by enhancing GABA, the brain's primary calming chemical. Multiple studies have found associations between long-term benzodiazepine use and increased dementia risk. A 2019 meta-analysis suggested the risk may be highest with long-term use of long-acting benzodiazepines. However, the relationship is complex. People taking these medications often have anxiety, depression, or sleep disorders, conditions that independently increase dementia risk. It's unclear whether the medications, the underlying conditions, or both contribute to the observed associations. The balance. Benzodiazepines can be life-saving for severe anxiety, but carry risks with long-term use, including dependence and potential cognitive effects. Thoughtful management. Use for shortest effective duration. Work with healthcare providers to develop tapering plans when appropriate. Consider alternatives like buspirone for anxiety or cognitive behavioral therapy. Never stop benzodiazepines suddenly. Withdrawal can be dangerous. Medication number 4, tricyclic antidepressants. Amitriptyline Elavil represents the older generation of antidepressants. While newer alternatives exist, tricyclics are still prescribed for depression, nerve pain, and migraine prevention. They're among the most anticholinergic medications still in common use. The 2015 JAMA Internal Medicine study mentioned earlier found that people with the highest cumulative exposure to anticholinergic medications over 10 years had significantly increased dementia risk. Tricyclics contributed substantially to this risk. However, these medications can be highly effective for certain conditions, particularly neuropathic pain where other treatments have failed. Informed decisions. For depression, newer antidepressants like sertraline typically have fewer anticholinergic effects. For pain, medications like duloxetine or gabapentin may be alternatives. If tricyclics are necessary, use the lowest effective dose. Regular monitoring and medication reviews are essential. Medication number 3, anticholinergic antidepressants, paroxetine. Paroxetine, Paxil, is unique among SSRIs because it has significant anticholinergic properties. While other SSRIs in this class have minimal anticholinergic effects, paroxetine blocks acetylcholine receptors more substantially. Research suggests that among antidepressants, paroxetine may have the highest association with cognitive concerns in older adults. The American Geriatric Society includes it on their Beers criteria list of potentially inappropriate medications for seniors. The distinction: not all antidepressants carry the same cognitive risks. The choice of specific medication matters significantly. Better options. Other SSRIs like sertraline or escitalopram have better cognitive profiles. Switching between antidepressants should always be done under medical supervision. Depression itself is a major dementia risk factor, so treatment is important. The goal is finding the right medication, not avoiding treatment. Medication number 2, inappropriate antipsychotic use. This represents one of the most concerning medication practices in geriatric care. Antipsychotics like quetiapine, risperidone, and olanzapine, Zyprazole, were developed for serious psychiatric conditions like schizophrenia. However, they're sometimes prescribed off-label for behavioral symptoms in dementia or sleep problems, uses for which they're not FDA approved and carry significant risks. Studies consistently show that antipsychotics can accelerate cognitive decline in people with dementia and increase risk of stroke and death. The tragedy is that many behavioral symptoms have non-drug solutions, and when medications are needed, safer alternatives often exist. Advocacy points. Question any antipsychotic prescription for sleep or behavioral issues. Ask about non-drug interventions first. If antipsychotics are truly necessary, ensure regular reassessment. Family involvement in care decisions is crucial. Medication number 1, high anticholinergic burden, polypharmacy. The greatest cognitive risk comes not from any single medication, but from the cumulative effect of taking multiple drugs with anticholinergic properties simultaneously. Research consistently shows that anticholinergic burden, measured by tools that score the cumulative effect of multiple medications, strongly correlates with cognitive decline risk.
A person taking low doses of several anticholinergic medications may face high risk than someone taking a higher dose of just one. Studies have found that people with the highest anticholinergic burden scores have double or triple the dementia risk compared to those with minimal exposure. The solution? Comprehensive medication reviews with doctors or pharmacists. Use of anticholinergic burden calculators to assess total exposure. Systematic deprescribing of unnecessary medications. Preference for medications with lower anticholinergic effects when choices exist. It's crucial to understand that association doesn't equal causation. These studies show correlations, not definitive proof that medications cause dementia. Many of these medications are medically necessary. The goal is appropriate use, not avoidance. Untreated conditions carry their own cognitive risks. Depression, anxiety, pain, and cardiovascular disease all increase dementia risk. Individual responses vary. Some people may be more sensitive to these effects than others. Risk must be weighed against benefit. Often the benefits of treatment outweigh potential cognitive risk. So, rather than avoiding necessary medications, focus on regular medication reviews with healthcare providers, using the lowest effective doses for shortest necessary durations, prioritizing medications with better cognitive profiles when choices exist, addressing modifiable dementia risk factors like cardiovascular health, physical activity, and social engagement, open communication with healthcare providers about cognitive concerns. The encouraging news is that medication-related cognitive effects are often reversible. When inappropriate medications are identified and safely discontinued or switched, many people experience cognitive improvement. The brain demonstrates remarkable resilience throughout life. Combined